Welcome to the Emergency Medicine Cases podcast. I'm your host, Dr. Anton Hellman, bringing you Canada's brightest minds in emergency medicine from EMC Studios in Toronto. EM Cases is part of SREMI, Schwartz-Reisman Emergency Medicine Institute, the nonprofit organization dedicated to improving EM care through research and education. The opinions expressed on this podcast are intended for information and education purposes only and should not be used to diagnose, treat, or prevent any medical condition, nor should they be used as a substitute for medical advice from a qualified practicing physician. This episode is brought to you by Easy Resus, the resuscitation assistant. This amazing app has drug dosing, equipment size calculation, treatment algorithms, all in under 3 clicks. Rapid access to life-saving critical info in a user-friendly interface. Try the app for free with the promo code EMCases or visit easyresus.com/EMCases. That's easyresus.com/EMCases. Here are some numbers. The mortality rate from eating disorders is 10 to 15%. So that's 1 in 10 or more people die from their eating disorder. And eating disorders might be more prevalent than you think as well. About 2 or 3% of North Americans have an eating disorder. And this ends up equating to about 1 million people in Canada and about 10 million people in the US. So what's the bottom line? Eating disorders are everywhere and can be fatal, and they have the highest mortality rate of any psychiatric illness. So the obvious question then is, why the heck don't ED docs learn about eating disorders? I'll leave this question for you to think about and just say this for now. It's about time we do. Our brand new guest experts today are Dr. Jennifer Tomlin and Dr. Samantha Martin. Dr. Tomlin is a dear colleague and friend of mine at North York General Hospital, an outstanding EM clinician with a special interest in eating disorders, whose excellent talk at the 2024 Emergency Medicine Update Conference inspired this podcast. Welcome, Dr. Tomlin.
Thank you, Anton.
And Dr. Samantha Martin is a pediatrician and adolescent medicine specialist at North York General and a clinical lecturer at the University of Toronto with extensive experience in both inpatient and outpatient adolescent eating disorder care. Welcome, Dr. Martin.
Thank you.
All right, let's jump into a case. A 16-year-old male comes in with mom with vague GI complaints. You take a thorough GI history and find no red flags. Vitals include a heart rate of 50, a blood pressure of 85/40, and a temp of 35.9. Some blood work is ordered, and it shows a mildly low K at 3.2, a mildly low hemoglobin, and normal liver enzymes. You dictate a note, and the most responsible diagnosis that you write at the bottom of your note is nonspecific chronic abdominal pain with no red flags for serious pathology. You discharge the patient and recommend follow-up with their primary care doc with instructions to return for a long list of red flag symptoms. We all know the diagnosis because that's the title of the podcast, but Dr. Tomlin, could you briefly review for us what went wrong with this case and what were some of the clues that this person actually has an eating disorder and what the doc should have done in an ideal world where every ED doc has an eagle eye for eating disorders?
You know, it's difficult. As emerged physicians, we see a ton of patients that have vague gastrointestinal complaints. And I think most of us are focused on making sure we're not missing anything surgical or life-threatening in our minds. Problem is that eating disorder patients often have gastrointestinal complaints. It's actually quite common. So in this particular case, vague gastrointestinal complaints, okay, fine. But if you look at the vital signs, which are vital, they're off. Heart rate of 50. Blood pressure at 85/40. So the patient's got hypotension. And although technically not hypothermic, the temperature is a bit low at 35.9. Looking at the blood work, potassium's a bit low at 3.2. Why is the potassium low? Why does a healthy 16-year-old have a low potassium? Hemoglobin being a bit low, also, especially because this is a male, why is the hemoglobin a bit low? I don't know, maybe he does has thalassemia or something like that. But you should have an answer to that question. So, in this case, there are no red flags for a surgical or life-threatening gastrointestinal complaint. However, there are multiple red flags for an unstable eating disorder.
Okay. So this is not an uncommon scenario where an eating disorder is missed in the emergency department. And we're going to talk about why this is so important in just a bit. Let's first talk about why they're so tricky to diagnose. So, Dr. Martin, how can eating disorders be sort of elusive to your emergency physician?
They absolutely can be elusive. The literature even describes eating disorders as one of the great masqueraders in medicine. The prevalence is increasing. There's excellent data from the COVID-19 pandemic. In Ontario, we saw a 66% increase in ER visits for adolescents presenting with eating disorders. This data we saw internationally. And we know that these patients are using the healthcare services, particularly the emergency department. In the States, it's been shown that about 16% of young people presenting to the emergency room have a clinically significant eating disorder. Yet, 30 to 50% of eating disorders go undiagnosed. So there's a few factors that have been identified as to why this diagnosis is so difficult. Looking at it from a healthcare provider perspective, one major thing is lack of education. When we survey residency programs in the States, for example, a survey looked at 637 programs, residency programs, pediatrics, family medicine, internal medicine in 2014, and it found that only 42 of those programs offered formal training in eating disorders. A more recent study actually surveyed emergency physicians' knowledge and training, and they found that about 1.9% of 162 emergency medicine physicians completed a rotation in residency, and 93% were unfamiliar with the American Psychiatric Association practice guidelines on eating disorders. So lack of education is a huge factor. Another point, patients often get missed because they don't fit that historic phenotype of an eating disorder. I think that case you started with highlights that, a male. We miss males, we miss young people, we miss racial minorities, we miss transgender youth. We're not asking. Diet culture and weight stigma. In North America, the cultural pressure for thinness and excess value on weight loss can delay recognition. A healthcare provider or even a family member may not perceive that a young person who's of normal weight or even an elevated BMI, who's had significant weight loss or is engaging in unhealthy eating behaviors, is sick. So I think that it's really important that we understand what our own weight bias is. And medically, as that case presented, eating disorders, they affect all organ systems. They present with a myriad of vague symptoms, and many illnesses can mask an eating disorder. Weight loss, well, we have to rule out celiac, secondary amenorrhea. So from my personal experience, many patients actually come to me after being seen in the emergency room, referred to subspecialists. For example, gastroenterologists will refer after the patient's been seen multiple times. I get referrals from gynecology for secondary amenorrhea, and it's 6 months to a year. This young person may have been struggling because of an eating disorder. The patient factors play a big role. So denial, it's quite common in anorexia nervosa. We find that patients often will minimize their symptoms. They may not share their symptoms with a healthcare provider or a family member, rationalize symptoms. And they often have a lack of insight into their eating behaviors. So that can be a barrier to sort of presenting to the emergency room to say, hey, look, I'm struggling with my eating. Even trickier is that these young people and adults, they're often really bright, really articulate, really competent in other areas of their life. So you're sitting with this young person who has this vague complaint of constipation, dizziness, and they're telling you they're the best athlete on the team. They're getting 95% average. They have lots of friends. So it's a mismatch in what you're looking at. They don't feel sick. They don't think there's a problem. And lastly, I'd say shame. So we see this with a lot of young people, particularly with bulimia or binge eating disorder, and parents. And we know shame is a barrier to health-seeking behavior. So take-home point, eating disorders should remain high on the differential for medical and psychiatric presentations in youth presenting to the emergency department.
That was so incredibly thorough and well thought out. Thank you. That was excellent. So again, it's lack of education, patient factors like denial, the phenotype isn't always what you expect, and the shame of the patient and the parents can really make this diagnosis elusive. And we'll get into a little bit more how the presentation can be elusive just from all the vague complaints and when we really need to consider this diagnosis. So one of the big misconceptions about eating disorders is that they're obvious just by looking at the person. And it's not surprising that only 1 out of 250 patients with an eating disorder have a chief complaint that specifically mentions eating disorder. So, Dr. Tomlin, how is it that patients with a normal BMI who don't look malnourished or underweight can have a life-threatening eating disorder?
That's an excellent question. First of all, especially in children and adolescents, BMI is a very, very imprecise measure of their health. With children and adolescents, we should be looking at growth curves. Growth curves in kids are very, very important. It's very important to look at historically, what has this person been throughout their whole life? If they have been, 50th percentile for height, but they've always been 90th percentile for weight, and now they're coming in and they don't disclose to you that they've lost weight, but if you had the advantage of having that growth curve and now you see that they're actually 60th percentile for weight, they will probably still look quite healthy, but that's not healthy. Losing weight, dropping off your growth curve in childhood or adolescence is abnormal. It is always abnormal.
All right, so it's more about the change in weight than the actual weight itself. And I guess the bottom line there is a normal BMI does not rule out an eating disorder.
Absolutely. And I do recognize that as emergency physicians, we probably do not have access to growth curves. And fair enough. However, just want to really push home the point, please don't count on BMI.
One question that is important to ask is, if you don't have access to the growth chart, is what was your highest previous weight? Because we have seen more and more in the data now, and we're using this more as a marker of severe malnutrition. So not just BMI alone, but weight suppression, which is the difference between your highest weight and your current weight. And that has been shown to be a predictor of medical outcomes. So certainly a young person who's less than 70% of median BMI, or what we call a treatment goal weight, is quite unwell. So is a person who's lost more than 10% of their body mass in 6 months. So that is a question where you can do the math without the growth chart there. There's excellent data. We see it in the literature, we see it clinically, that these young people who have lost their weight suppression is high, or they've lost significant weight but still have a normal BMI or even elevated, have the same medical complications as a young person with anorexia nervosa and even higher levels of eating disorder psychopathology. And these are the patients that we miss. Unfortunately, they may be told that they look well, they don't look sick, they're not thin enough to have an eating disorder, and that perpetuates the psychopathology, the weight loss, and the behaviors.
It's fascinating. So it's more about the delta than the absolute weight.
It's both, but the delta is an important measure to apply to your risk assessment of a young person coming in with weight loss.
Got it. Now that we have a bit of an understanding about why eating disorders are easily missed in the ED and the misconception that all patients with eating disorders look extremely thin, I'd like to dig into our understanding of the causes of eating disorders. So let's talk a bit about etiology. So we don't know that much about the underlying cause of eating disorders, unfortunately, but recently I understand we're beginning to uncover some of the important clues. Let's start with the misconceptions of the causes of eating disorders. So Dr. Tomlin, what are some of the misconceptions out there when it comes to the cause of an eating disorder?
I think probably the biggest one is the theory of control. That the person suffering with an eating disorder, their life is chaotic or other things in their life are out of control. So they choose to control kind of the one thing that they can, which is their eating, their bodies, that sort of thing. This is unfortunately a theory that still gets used and still is believed by some clinicians today. Not only is it wrong, it's harmful. The patient with an eating disorder is not in control. The eating disorder controls them. If clinicians are thinking that this is a control issue and the patient's in control, they're controlling their eating disorder, they want to do this, that they have a choice, that's putting the blame of their disease on the patient. Eating disorders are genetic, they are neurobiological, and they're environmentally influenced. Twin studies show that anorexia is 60 to 70% heritable. It is genetic. Simply put, I like this saying very much, genes load the gun and the environment pulls the trigger. In a genetically predisposed person, it takes maybe just that one thing.
Can you give us an example of what kind of environmental triggers there are?
Everybody always thinks social media. Okay, that is an environmental trigger. Societal pressures as an environmental trigger. However, I think some of the triggers that perhaps are not thought about are medical triggers. So in a genetically susceptible person, they get super bad gastro. In a healthy patient that is not genetically susceptible, okay, they'll have their 5 days of vomiting and diarrhea or whatever it is, might get a bit dehydrated, probably lose some weight, but then when they start feeling better, they go back to their usual eating patterns. If they had lost a little bit of weight, they'll gain it back and they'll go on with their life. In the genetically susceptible person that has that super bad gastro, when they lose weight, they are at risk of their eating disorder starting. They get into this negative energy balance, and that can be the trigger. So it can be the bad gastro that caused weight loss. It could be chronic illness. It can be multiple spinal surgeries, whatever. So there are medical triggers as well.
And Dr. Martin, in your experience, what are some of the common triggers? And I think the reason why it's important to recognize these is because, again, if we could pick this up in the emergency department, it might be that a child has a gastro and then comes in a week later or 2 weeks later and parents are concerned about them for whatever reason. That might be exactly the time when we can clinch the diagnosis. Are there any other sort of common triggers? So again, we're talking about the 70% or 60 or 70% genetic, and then the trigger is some environmental thing that happens. So what are some other examples?
Yeah, going off of Dr. Tomlin's point, I actually see kids come in after having their wisdom teeth taken out. It's another one. So dental procedures or surgery, really, any surgery. That's a big trigger. So when we look at other factors, there's individual factors that may predispose a young person. So personality, temperaments, when we think about anorexia nervosa, it's high-achieving, perfectionistic, fear of failure type sort of phenotype. That's not all, or impulsive personality. I think that young people who are in a specialized sport tend to be higher risk, particularly sport that does rely on a certain body type. They may not have pressure to be thin, but performance is dependent on their body type. And interestingly, another area we miss is boys. Boys have pressure to be fast. They have pressure to be muscular. So it's not all about thin and weight loss, muscularity. So that population, really understanding the pressures that a young person may be under, either self-inflicted or from their coach, to perform at a certain elite level as an athlete. Chronic medical conditions. Type 1 diabetes is known to have a high rate of adolescent eating disorders. Not uncommon for an adolescent to omit their insulin for the purpose of weight loss. Lots of binge eating disorder. Transgender youth, these patients need to be screened. So particularly biologic females who are transitioning to male, they have significant distress around their menstrual cycles, around their hips, their breast tissue. And in order to manage that distress, put simply, weight loss can help them feel safer and more aligned with their identity. They stop. Amenorrhea is a goal. They don't want breast tissue and they don't want any other fat deposition that triggers their dysphoria. We talk about family factors. Certainly, family dynamics and relationships can contribute to the maintenance or exacerbation of eating disorder pathology, but there is no evidence, and another misconception, that the parents cause the eating disorder.
Yeah, let's talk about that a bit more. So I hear this kind of in the hallways all the time. It's like, oh, those parents, the way they talk about being skinny and what they expect of their child and that sort of thing, that they've somehow caused the patient to have an eating disorder. And then, of course, you're talking about shame before, and that, this shame of the parents, it can be counterproductive, I imagine, in a treatment phase to blame the parents for the patient's eating disorder. Can you talk a little bit more about parents in terms of causality or risk factors for an eating disorder and what the parents' role is in diagnosing and assessing and managing eating disorders?
So parents have historically been blamed for their child's eating disorder, and we really need to shift that narrative. I don't know any other pediatric condition where a young person comes in really sick and parents take on so much blame and so much guilt. An adolescent coming in DKA, you don't hear a parent blaming themselves, and you certainly don't hear the providers blaming the parent. Something to think about. The blame is entirely unwarranted. We rely on parents to bring their child to get a medical assessment, to pick up on the red flags, to monitor for symptoms. And they're really, when it comes to treatment, the greatest allies to their child's recovery. But what healthcare providers need to understand is eating disorders come into a young person's life, and not just that young person, the entire family. They hijack the family system. So sometimes we do see parents finding themselves maybe engaging in behaviors that reduce distress or are trying to manage the risk the best they can. The resources are limited. It's a very lonely experience, and it's very frightening. So, for example, a parent may align with their teenager when they don't know what's going on and say, okay, you can be a vegetarian, of course, or okay, go for the half-an-hour run. It's better than the 2-hour session at the gym. Or okay, I'll plate smaller just so you don't self-harm or, get so distressed that your little sister gets upset. So those behaviors can be perceived as sort of aligning with the eating disorder, and there can be blame from healthcare providers who see that and say, oh, or the parents have their own body image concerns. But that is just not it. It's them trying to figure out how to manage their sick child. So really, really take-home important point is a non-judgmental approach to parents and a compassionate approach to parents is critical. We know that treatment is better when parents have experiences with healthcare providers who do not blame. Treatment, an adolescent with an eating disorder can't make a healthy choice about their eating. Just like a young person with diabetes, they need their parents to help them carb count, to help them give insulin. We can't expect an adolescent with an eating disorder to suddenly know how to nourish their bodies and manage their distorted cognitions. It's a team approach that heavily, heavily relies on the parent taking control of decisions related to food and exercise. We rely on them. They are absolutely critical to a young person's recovery. So blame is so counterproductive.
All right. So many misconceptions we've already covered. I just want to review. So these environmental risk factors, let's call them, there's a huge variety, everything from pretty much any acute illness or surgery or even a dental procedure. Elite sport is a risk factor. Chronic illness is a risk factor. Transgender is a risk factor. Perfectionist type personality, that's a risk factor as well. And there's probably a long list more, but those are some of the ones that I think is important for us to understand, that these are the sort of the risk factors / triggers. And so when we're suspecting that someone might have an eating disorder, we might ask in the history, has anything happened recently like this list of risk factors we just outlined? Do you dread doing your clinical notes every shift? Do you feel like you can never get ahead of charting? If you're shaking your head yes, keep listening. Freed is an AI scribe that listens, transcribes, and writes medical documentation for you. Notes are written in your style and ready the moment the patient encounter is over. Just imagine leaving work at the same time as your last patient. Freed is HIPAA compliant, secure, and takes less than 30 seconds to learn. Artificial intelligence can't replace you, but it can do the administrative work that no human should be subjected to. All the magic happens in just a few clicks so that you can spend less energy on charting and more time on doing what you do best. Freed learns your style over time, just like a human scribe, and it'll never quit on you. More than 6,000 of your clinician colleagues already use Freed AI. Get back to spending your clinical time caring for patients and let Freed AI do the rest. Head over to getfreed.ai and use the code EMC50 to receive $50 off your first month with Freed. That's getfreed.ai with the code EMC50. I don't think yet we've really convinced emergency providers that this is definitely in their wheelhouse. I mean, we have mentioned some really interesting stats about the lack of education in emergency medicine for eating disorders, but there might be some listeners out there who believe that eating disorders really aren't in the wheelhouse of the emergency physician. I mean, we already drove home the point that the number one cause of death in adolescence is eating disorders. So there's one reason right there. EM is at least partly about saving lives, right? But Dr. Tomlin, what are some of the other reasons we should consider eating disorders to be an emergency diagnosis?
Absolutely. And if they're coming in to see us, we have the opportunity to possibly make the diagnosis and then hopefully assist them into getting into treatment faster, because we know that the earlier that the eating disorder is picked up and the faster they can get into good treatment, they have much better outcomes. The third thing is that there are a myriad of life-threatening complications with eating disorders. And as you mentioned, Anton, us emerge docs, we sometimes want to deal with the life-threatening stuff. But we're not going to know that unless we look for it.
Excellent. We're going to get into the details of all the life-threatening complications of eating disorders a little bit later in the podcast. Related to the dangers of eating disorders and why it's important for EM docs to pick them up and manage them appropriately is the urgency of diagnosing them early, as you just mentioned. So, Dr. Martin, could you talk a little bit more about why it's so important to pick up eating disorders early in their course?
Yeah, so treatment delays are problematic twofold. One is because of the adverse medical complications and high mortality rate, which we've discussed. A lot of the medical complications from eating disorders are reversible with appropriate and timely nutrition rehabilitation. Not all. And so a young person who has an eating disorder hit during adolescence, if they don't get treatment and weight restore, there are potentially irreversible complications from that. For example, growth stunting. Other irreversible complications we worry about is issues with bone health, so risk of osteopenia. So the medical complications become much more complicated and potentially irreversible if we don't treat early. The second part is the psychopathology becomes more embedded over time. And that translates to more challenges with respect to treatment and their prognosis. These young people who struggle with eating disorders for years, it's very, very difficult to undo some of the distorted cognitions that have really entrenched themselves. It is possible, so my message is not that it's not possible. However, if there's an opportunity to identify these young people before that ball rolls down the hill and this young person gets sicker and sicker, that can dramatically change the outcome of this young person's life. So an emergency medicine physician does have a role. They have a big role. They can actually change the outcome of a young person or adolescent's life by even asking the question. You don't need to be perfect at understanding it, even diagnosing it. But if you have a red flag or a concern, connecting them to somebody else or consulting your colleagues or going that extra step, they that might get them in the door enough to prevent something that can become chronic and very debilitating.
I think this is a good time to talk about the recovery rate for eating disorders, because I think another misconception out there is that if someone has an eating disorder, well, there's not much we can do and they just won't recover. Dr. Martin, what approximately is the recovery rate for eating disorders? And I'm assuming it depends on how quickly they get into treatment and the type of treatment they get. Obviously, it's going to vary widely, but just ballpark, what do the recovery rates look like?
So the general rates of recovery follow the rule of thirds. About 1/3 have a full recovery, 1/3 would have a partial recovery, and 1/3 may have a chronic eating disorder.
Okay, so I think that's important to understand because, again, the earlier these are diagnosed, the higher their chances of recovery, because there's this idea that once an eating disorder has been missed, that over several years, it then becomes harder and harder to treat. Before we get into the assessment of these patients in the ED, we need to get some kind of definitions out of the way. It's important to know the different types of eating disorders because they present differently. Can you briefly define for us the most common types of eating disorders? I've heard there's anorexia nervosa, there's bulimia nervosa, there's binge eating disorder, there's restrictive type, there's all these different names. What's an easy way for us to think about the different kinds of eating disorders and how they present differently?
You can separate the types of eating disorders into body image-based and non-body image-based. So one of the most common is anorexia nervosa, and there are 2 subtypes to that diagnosis, a restrictive subtype and a binge purge subtype. To meet criteria for anorexia nervosa, 1, there has to be a demonstration of restricted calorie intake relative to one's energy requirements, significant low weight for that person's age, their sex, and their physical health. So there is no weight definition. They don't need to have a weight criteria to get this diagnosis. B, an intense fear of gaining weight or behaviors that consistently interfere with weight gain, despite being at low weight. So if a young person is not disclosing they have a fear of gaining weight, that does not preclude this diagnosis. If they are engaging in behaviors that consistently interfere with weight gain, that meets criteria. Altered perception of one's body shape or weight, preoccupation with weight or shape, persistent lack of acknowledgement of the seriousness of one's low weight. And in terms of the subtype, the restrictive subtype is the weight loss is achieved primarily through dieting, fasting, or excessive exercise. Binge purge subtype, a young person is, or an adult is having repeated episodes of binge eating and purging. Purging can be self-induced vomiting, laxatives, diuretics, and they're restricting, and they're underweight. So that's anorexia nervosa. Atypical anorexia nervosa is a relatively newer diagnosis in the DSM-5, which captures those patients we were discussing earlier that have a normal or elevated BMI. Essentially, these patients meet all the same criteria for anorexia, yet their weight is normal or above normal. The third body image-based eating disorder is bulimia nervosa. So bulimia is characterized by repeated episodes of binge eating. The key is a true binge is a person would describe feeling out of control. They really can't stop. They eat past the point of fullness. They have shame. They eat alone. It's distressing. And in bulimia nervosa, the binge eating episode is followed by what we describe as an inappropriate compensatory behavior to prevent the weight gain and manage that guilt. Self-induced vomiting, laxative abuse, medications, excessive exercise, fasting. Those are all types of purging. So to meet criteria for bulimia nervosa, the binge eating and compensatory behavior has to occur about once a week for 3 months. And the person has to endorse preoccupation with body shape and weight. So those would be the 3 body image-based eating disorders that are quite common. In terms of presentation, well, the presentation to the emergency department are typically the medical complications of malnutrition or psychiatric distress from, self-harm, suicidality, low mood, anxiety from the eating disorder. Things like chest pain, palpitations, syncope, nonspecific abdominal pain, constipation, fatigue, weakness, those type of things. With bulimia, I will highlight a couple unique presentations. Hematemesis, reflux, epigastric pain. Those we see more commonly. Dental pain and the cardiac symptoms from electrolyte disturbances would be more common. So moving on to some of the non-body image-based eating disorders. Avoidant restrictive food intake disorder, ARFID. This is also another, I'd say, relatively new classification in the DSM-5. It is defined as a disruption in eating pattern as evidenced by persistent failure to meet appropriate nutritional or energy needs associated with one or more. It doesn't require a lot, significant weight loss, or, as Dr. Tomlin mentioned, failure to achieve expected growth, not normal. Marked nutritional deficiency, anemia, for example, reliance on enteral feeding or oral nutrition supplements, so the patient who requires 3 boosts a day to maintain their weight, significant interference with psychosocial functioning. The eating disturbance can't be due to food insecurity. There can be no body image associated with it, and no mental health or medical condition that can explain the eating disturbance and presentation. Presentation to the emergency room. Sometimes we see kids come in with food refusal, progressive weight loss, and again, the medical complications of weight loss. ARFID has been sort of organized with 3 subtypes that can help when you're taking a history that might stand out. One is that there's a subtype of kids who just have a lack of interest in eating. The second is kids who have sensory or textural issues with eating that really impair appropriate intake. And the third is a subtype or a group of young people who have a fear of an aversive consequence when eating. That one classic history would be young person was growing well, thriving, goes to a party, has a hot dog, chokes on the hot dog, next day starts to get really anxious about eating, never has a hot dog again, and all of a sudden food groups start to fall off and anxiety around eating becomes prominent. So they may present in the emergency room with progressively worsening anxiety with eating and weight loss.
All right, so that gives us an idea of the different types, the different categories of eating disorders and how they might present differently. We will have a chart or a table in the show notes that outlines all of these. I think it's important to review them. And as you said, it really ties into what kind of clues on history that you do want to ask for to help nail a diagnosis. And now a word from one of our sponsors, Easy Resus, the resuscitation assistant. Easy Resus is thrilled to announce that they are now available for institutional access. In addition to providing the app for all employees in your organization, this means access to exclusive features like printable protocols with calculated medication doses, customizable content to fit your local protocols and practices, access to Easy Resus on computers via the web-based version, and much, much more. To learn more, visit the institutional license section at easyresus.com. And as always, you can download Easy Resus and use the promo code EMCASES, that's EMCASES, one word, to get your 2-month free trial on an individual subscription. We already established that we miss eating disorders in the emergency department all the time. And so the question comes up, should we be doing some sort of universal screening, similar to domestic abuse? It's still a little bit controversial of whether or not we should do universal screening for domestic abuse. We know that it's prevalent, and you think that if you did universal screening for domestic abuse, that we'd be able to pick it up and prevent morbidity and mortality in those patients. What about eating disorders? Is there any evidence-based screening tool that we should be using, say a triage for all patients, say between the ages of 12 and 25, so that we can pick up eating disorders early and get them into treatment and save some lives?
There's the SCOFF questionnaire, which is the most validated tool for eating disorders. The S stands for sick, the C stands for control, the O stands for 1 stone, F stands for fat, and the other F stands for food, SCOFF. It's a self-report questionnaire consisting of 5 questions, and it's used to assess core features of anorexia and bulimia. A score of 2 or greater is a positive score and warrants further assessment. It is not a diagnostic tool, and it really can't differentiate between the two eating disorders. There's not enough evidence for its broad use, really, because it can't be applied to a heterogeneous population. It's primarily been studied in females, and you can't pick up the full spectrum of eating disorders. The specificity has been shown to be around 73 to 94%, and the sensitivity is around 72 to 100%. So about a 30% false negative. I think it's most likely helpful, the SCOFF questionnaire, if a patient screens positive and additional clinical assessment occurs after that.
All right. So I can imagine a day where patients in waiting rooms between the ages of, say, 12 and 25, they're waiting for a few hours to see the emergency doctor anyhow. Why not give them a form? They fill it out themselves, so you don't need a nurse to ask the questions. It's not going to add any time to them being seen by a physician. It gives them something to do while they're waiting. It sounds like the accuracy isn't perfect. Neither is any tool. But this to me sounds like something that could be implemented in emergency departments that see a lot of people between the ages of 12 and 25. And maybe this is one way that we could pick these up earlier and prevent chronic illness. I guess we need a large RCT to answer that question for sure, but some things are just common sense. And to me, that makes a lot of sense.
I think every adolescent should have a general psychosocial screen that comes into the emergency room when possible. And part of that general HEAD psychosocial screen, the HEADS assessment, the E stands for eating. So there's a lot that could be picked up even just asking, how's your eating going? How's your nutrition?
Yeah, we don't want to add more to emergency physicians' workload, that's for sure, but filling out a questionnaire on their own while they're waiting, again, I think is a sensible idea.
The only downfall, Anton, would be we'd have to provide them with pens and clipboards.
Or, just ask them to fill it out on their phone and submit it.
Well, the new generation,
Yeah. Dr. Tomlin's giving away a little bit about her age. All right. Let's move on to some details about the clinical presentation. You already had mentioned, Dr. Martin, a bit about the clinical presentation when you talked about the different categories and subtypes of eating disorders. What are the typical chief complaints associated with eating disorders in the emergency department, and how might they mask the underlying disorder? So in our case at the top of the podcast, we had a patient with vague GI symptoms. That's a very common presentation. In fact, I think it's the most common presentation. Are there others that we should be on the lookout for, Dr. Tomlin?
Oh, absolutely. It is the very rare patient that walks into the emergency department volunteering that they have an eating disorder and they're worried about themselves. So I think we have to be completely aware of what they're coming in with and what is worrying them. So, there's a myriad of things. It can be palpitations, can be syncope, it can be cold intolerance. They've lost their period for the last few months. They might be coming in with increasing depression, increasing self-harm, suicidality, abdominal pain, which can actually be quite severe, constipation, gastritis, acid reflux, come in with facial swelling. That would be from vomiting, parotitis. If they're purging and vomiting, they can come in with pharyngitis. They can come in with hematemesis. They can come in with a broken bone that does not have a good explanation as to why it got broken.
All right, so there's a long list. I just want to highlight some of those. So we see tons of patients with abdominal pain in the emergency department, and not infrequently, we do a massive workup for them in the emergency department, and everything comes back unremarkable. I just want to highlight that this is when, we should have that cognitive forcing strategy. Abdominal pain, NYD, think about an eating disorder.
Yeah, ask the question.
Yeah.
Also, syncope, NYD, ask the question.
Yeah, because those are two very common presentations that we often end up with an NYD at the end.
Yeah.
Excellent. All right. So those are some of the chief complaints that should trigger us to consider an eating disorder. I want to dig into some key aspects of the history taking for patients you suspect of an eating disorder. So, Dr. Martin, can you walk us through a focused history that can help us identify potential eating disorders tailored for the emergency doctor. So especially when patients present with nonspecific complaints like fatigue or dizziness or GI symptoms.
Yeah, so the aim is to understand the patient's eating behaviors, evidence of dieting practices, their weight history, and any purging methods. I think it's important, particularly if a young person's coming in without offering their challenges with eating. If they're coming in, let's use the example of abdominal discomfort and constipation, to frame the question around the chief complaint. Generally starting off to see what they'll give you, saying sometimes suffering from constipation can change how you eat. Has that ever happened to you? Have you ever had issues with eating? Has anyone ever expressed concern about your eating? So I think, I'll take a step back if you can and have the time to talk to the young person on their own, but always get collateral, because that patient may say, no, they haven't. No, everything's fine. And it's not uncommon to see a parent kind of sitting in the back or sitting beside their teen, shaking their head. Collateral is critical. And then briefly, get a sense. How many meals do you eat each day? How many snacks? Give me a day of eating for you. So it gives you a snapshot of how much they're eating, what types of food. Are there foods that you avoid? Are there food groups you don't like to eat? Do you care what's in food? Are you somebody to look at nutrition labels, calorie count? Do you ever avoid food because you're worried that it's going to make you sick, or the sensory or textural aspects of food concern you? So those two questions are really getting at that ARFID diagnosis. What's the most you've ever weighed, if you know? And what's the least you've ever weighed, if you know? Questions around eating disorder cognitions. Are you fearful of gaining weight? Do you have a drive to be more muscular? So not just focusing on weight loss, muscular. And then honing in on the preoccupation. How much time is this taking up for this young person? So how much of your day are you spending thinking about food and your body? Binging and purging behaviors. We've sort of touched on this when we were going through the diagnostic criteria, but do you ever feel out of control when you're eating? Asking about a binge specifically, and then asking about, do you ever engage in activities to help manage the guilt or compensate for the binge? I find it helpful, again, to give examples if they're not going to offer. So, for example, some young people who struggle with eating tell me they eat a lot, they feel really out of control, it's a really distressing experience. After that, they may actually decide to eat less the next day, or increase their exercise, or make themselves vomit. What's your experience? So that kind of approach might provide more answer. Getting a brief sense if they are exercising, getting a sense if it's appropriate or not appropriate, meaning do they exercise alone? How much are they exercising? Do they feel guilty if they can't exercise? And are they engaging in exercise as a weight loss measure? So those would be sort of the main questions to grasp if a young person is struggling with eating. Review of systems obviously must be very thorough, and in a female, you must ask about a menstrual history. And then please don't forget, screen for comorbidities, so suicidality, self-harm, substance use, mood, and anxiety. They're all quite common in young people struggling with eating disorders.
So those are some of the important questions to ask to really discover what's going on with a patient with an eating disorder. Is it fair enough to say that we should, at minimum, just ask them a bit about their eating habits, their exercise habits, their menstruation, their psychiatric state in general, substance use, their highest weight, lowest weight, and what they think about their weight?
Yes, I think that would, with the addition of a parental collateral, potentially be very helpful in picking up an underlying eating disorder.
Yeah, I can't agree more with Dr. Martin saying you need the collateral information. This is not one of those emerge visits that we purposely exclude the parents. Obviously, in some situations, it's appropriate. STIs, birth control. We're not going to be asking the parents' opinion on that, of course. But in this case, you're going to talk to the patient alone, but you absolutely have to talk to the parent. And I would recommend doing it alone, away from the patient.
All right. Let's move on to the physical exam. And the physical exam, of course, always starts with the vital signs. So, Dr. Tomlin, you already mentioned near the top of the podcast that vital signs are vital in eating disorders. What do we need to know about how to obtain reliable vital signs in the patient suspected of an eating disorder? Because this isn't just something that you're just going to read off the triage note and note to yourself, these are the vital signs, and just go with that. I understand it's a bit more complicated with patients who you suspect might have an eating disorder.
Yeah, absolutely. If the triage vitals are abnormal, then pay some attention to them. But if the triage vitals are normal, disregard them. They need a whole new other set of vitals that are properly done. Remember, the patient coming into the emergency department, they may be anxious. Maybe they were forced to go there by their parents. There's some conflict going on. They're scared. They're pissed off. So that's all going to put them into their sympathetic overdrive. So in somebody that is baseline bradycardic and hypotensive, that sympathetic drive can actually perhaps make them have normal-looking vitals. So once you're doing your assessment, the vitals have to be redone. And the first thing that needs to be done is the patient has to lie down on a stretcher, completely flat. So supine, but completely flat, resting for 10 full minutes. At that point, before even doing the vitals, get your ECG. You need a resting ECG. So do the ECG, and then first part of your orthostatics can be done. So then you're going to get the resting heart rate and blood pressure. Once that is done, the patient immediately stands up. You're going to wait a full 2 minutes and then repeat the heart rate and blood pressure again.
All right. So I think that's a key take-home point there, that apparently normal vitals could mean that at baseline, their heart rate is 38. And the only reason their heart rate right now is 72 is because they're scared. They don't want to be there. They're upset. You had mentioned orthostatic vitals. Could you just explain why those are so important in the patient with an eating disorder? Because we don't do orthostatic vitals on everyone. And some people would argue that orthostatic vitals in the general emergency population isn't that useful. There's some evidence out there that it's actually not that useful. But in this particular situation with a suspected eating disorder, why are orthostatic vitals so important?
Yeah, they are crucial in this patient population. The reason why they're so important is they are going to help you determine whether the patient is stable or unstable. So daytime heart rate less than 50, nighttime heart rate less than 45. If they have orthostatic tachycardia, the number will vary by institution and hospital. General rule, anything over 30 to 35 of a heart rate jump on standing is considered unstable. And then if there's orthostatic hypotension, so a systolic blood pressure drop of 20 or more, or a diastolic drop of more than 10.
One of the important points about assessing bradycardia is that if you're seeing an athlete with bradycardia, that's not normal. Exertional tachycardia is not reflective of an athletic heart, nor is bradycardia. You have to distinguish between malnourished heart and the athletic heart. And bradycardia in an adolescent who's an athlete is not normal. It needs to be further assessed.
Great point. So that's interesting to know. I wasn't aware that bradycardia in an adolescent is abnormal. I assumed that it was kind of similar to the adult who is a triathlete who has a resting heart rate of 42, that can be perfectly normal. So that's good to know.
Another point about triage vital signs, if they're normal, yet the young person has been sent in by a community physician or primary care doctor who has a documented, palpable heart rate of 45 or an ECG that shows bradycardia, that should be the data you consider over any vital signs in the emergency room. A young person who is seen and sent in and bradycardic in the outpatient setting coming in and you don't get any data to support ongoing bradycardia or vital sign instability, ignore it. Take the outside ECG.
Okay, a good analogy for that is the fever in an infant,
Exactly.
Parents say, oh yeah, they definitely had a fever of 38.5 at home, and then they come and their triage temperature is normal. You need to pay attention to that home fever. because that kid could be septic even though their temperature currently in the emergency department is normal. I want to move on from vital signs to cardiac complications. We've already just talked about bradycardia, orthostatic blood pressure drop, orthostatic tachycardia. Dr. Tomlin, could you just go over for us some of the key cardiac complications of eating disorders besides bradycardia? These are super important because it's the cardiac complications that are the leading cause of death in these patients. So what are sort of the top 3 or 4 or 5 serious cardiac complications of eating disorders that we should know about?
So the cardiac complications of eating disorders, there's a myriad of them. And this is due to the chronic and severe malnutrition that the patient's bodies have been going through. And it's crazy, but cardiomyocyte atrophy actually occurs in these patients. Their heart atrophies. Due to that, they can have decreased cardiac output. They can get congestive heart failure. And these first 2 cardiac complications, I'm mentioning them together because you really need to be very judicious with any IV fluids in these patients. Always think about your use of IV fluids in any eating disordered patient. You can also get mitral valve prolapse. You can get pericardial effusion. And then dysrhythmias. Sinus bradycardia is by far the most common rhythm. However, you can see QT prolongation as well.
We don't routinely weigh patients ourselves in the emergency department. The pediatric patients are usually weighed at triage, we hope, and they get sort of a quick weight. And I think this is kind of a similar thing to the vital signs, that there's a particular way of weighing patients who you suspect of an eating disorder. It's not just kind of hop on the scale, hop off the scale, a triage. How do you suggest we go about weighing the patient suspected of an eating disorder, and why is it so important to get an accurate weight in the emergency department?
So this is my method. First thing you're going to do is you're going to get the patient to give you a urine sample. That's the first thing. If available, if you can ask for a post-void residual after that urine sample, that's also helpful. This is to decrease the effects of potential water loading by the patient and also allow you to catch it if it's occurring. Then the patient is going to be put into a gown, and it's gown only. Reason for this is you want to try to decrease the chances of hidden weights on the patient. And then you're going to ask them to step backwards on the scale. So this is known as a blind weight. The patient does not see the number, and whoever's weighing the patient should not tell the patient the number. For these patients, seeing their weight, the number on the scale, can be super distressing. So we want to avoid that.
Some important details of just weighing the patient. I want to move on with the physical exam here. What are the key physical signs that may suggest an eating disorder? Like, what are some of the clues from the end of the bed, so to speak, that a patient might have an eating disorder besides them looking very thin, which, as we've already established, many of them don't?
Notable physical features in a young person with an eating disorder can be broken down into signs related to restriction. So we've talked about abnormal vital signs. We've talked about deviation from previous growth trajectory. Looking at them, they may be pale, have dry, sallow skin, orange discoloration of their palms of their hands and soles of their feet. Lanugo hair, which is this soft, fine, downy hair that often presents on the face or arms. Signs related to vomiting, so angular stomatitis, dental enamel erosions. Russell's sign, so this is an abrasion or a callus on the knuckle from self-induced vomiting. Parotid gland enlargement, and always have a look at the back. Bruising or erythema over the spinous processes may suggest excessive exercise. Lots of sit-ups, lots of exercise on their back. And you want to make sure there's no concern for skin breakdown in the really emaciated young person. So those would be the main ones.
You can also look in oral pharynx, not only for enamel erosion, but actually looking at the palate, hard and soft palate, for petechiae, which can be seen with repetitive vomiting. And then some patients actually can get facial petechiae as well.
I didn't mention this because we've talked about cardiac presentations, but most of these patients have a delayed cap refill, acrocyanosis, and cool extremities.
A word from our sponsor, Metricaid, the experts on scheduling systems. Since 2015, I've been using Metricade, the incredible self-scheduling system that has made my life and the lives of my colleagues so much easier. Metricade can really help minimize the drawbacks of shift work we all know so well by not only ensuring equitable distribution of shifts, but also integrating circadian rhythm-friendly recovery time into their algorithms. They minimize my sleep deprivation, which allows me to be a better EM doc on shift. I can take better care of my patients and still have energy left after my shifts to enjoy other aspects of my life. Check out metricade.com/EM cases for more details on how this awesome scheduling system works. I think that's all we'll say about physical exam for now. There's actually a lot to know to do the physical exam right. There's lots of nuances that we've talked about that we normally don't do in the emergency department, the way we weigh patients, the way we take vital signs, etc. Next up is investigations. So again, we'll detail this in the show notes, and our EMRs should really have an order set to make it easy for us. But I just want to go through some of the essential investigations we need to send off in the patient who we suspect might have an eating disorder. Dr. Tomlin, besides an ECG, which we've talked about a bit already, what should we order for these patients and why?
So other than the ECG, we are going to get the urine. And with the urine, we are not looking for a urinary tract infection. We are looking at specific things in the urinalysis. Number one, specific gravity. If it's very low, it's indicative of water loading. There may be some ketones in the urine, starvation. And then you also want to look at the pH of the urine, because if it's greater than 8, there's probably active catabolism going on. Going on to blood work, you're going to look at the CBC because you want to look at the cell lines. You want to see if their hemoglobin is low, if their white count's low, if their platelets are low. In severe and chronic starvation, you can get a shutdown of all 3 cell lines. You're going to get creatinine. Creatinine, you want to look for kidney injury, which is common in these patients. You're going to get electrolytes. Hyponatremia is common. Potassium, if it is low, be very suspicious that there is repetitive vomiting or diuretic use. Chloride often can be low. Again, very suspicious for vomiting. And then you actually do want to get CO2 or bicarb. This is important because it's often elevated in purging patients that are vomiting. Your electrolytes can really give you good signs into purging vomiting behavior. Next thing you're going to get are the extended electrolytes. And these are quite important for a different reason. Calcium, magnesium, usually you don't have critical results with these, but they can be low. The phosphate is super, super important. If the phosphate is low, then this patient is at high risk for something called refeeding syndrome. Refeeding syndrome is when a person that has had very low minimal nutritional intake for a period of time, if they suddenly go on to increase their nutrition, it can cause massive electrolyte disturbances that it's a storm and it's fatal. The key here is that if your phosphate is low, that is a high-risk patient for refeeding syndrome. That is not somebody you're going to send home without calling your pediatric or internal medicine consultant. With regards to lipase and amylase, lipase is very good, obviously, for detecting pancreatitis, which is a complication of eating disorders. However, it is not useful for signs of vomiting. If your center will allow you to do it, send off an amylase that is often elevated in patients with recurrent vomiting.
Can I add, if there is lack of clarity on the diagnosis, particularly a patient who may come in with only weight loss or some nonspecific GI symptoms, an ESR can be helpful when you're in an adolescent, particularly to rule out IBD. It's one of the top differentials for weight loss in an adolescent. So adding an ESR can be helpful if, for example, you see that the CBC doesn't align with what we typically see with an eating disorder. A young person or an adolescent with an eating disorder should never have a raised ESR, ever. So if you get it and it's raised, you have to rethink your differential.
That's a great list of what to look out for on the blood work and why we need to order each of those tests in the patient who we suspect has an eating disorder. What if the blood work comes back normal? Often in general, in emergency patients, before we get investigations, we have a pretty good idea what their disposition is going to be. If we think they're probably good enough to go home and then their blood work comes back normal, it's even more evidence that the patient's okay to go. How is this not true in eating disorders? What do you do with normal blood work?
Nothing. Just like normal triage vital signs. Do nothing with it. Normal means nothing. Abnormal means something.
Okay. So the bottom line there is it is not uncommon to have a severe eating disorder with perfectly normal investigations.
You got it.
All right. We've already covered cardiovascular complications and electrolyte complications, some of which are life-threatening. Pretty much every organ system can be affected in the patient with an eating disorder. We're not going to dive deep into every possible complication, but for emergency physicians, what are sort of the immediate life threats that we need to know about, Dr. Tomlin?
So the life-threatening complications, as we just, mentioned about the blood work, so hypokalemia is an immediate life-threatening complication. Hypophosphatemia is also a potential life-threatening complication. Moving away from blood work, gastrointestinal complications that can be life-threatening. You can have esophageal rupture from vomiting. You can have acute gastric dilatation, which can actually impede venous return, causing necrosis and perforation. That's not good. You can also get something called SMA syndrome, so superior mesenteric artery syndrome. This is essentially due to a loss of the fat pad around the mesentery of the duodenum. So then the aorta and the superior mesenteric artery actually cause almost an obstruction of the duodenum. So they can get a small bowel obstruction. You can get pneumothorax, pneumomediastinum. If they have very low platelets, they're at increased risk for bleeds. Small head injury, they can have intracranial hemorrhage. And the last thing that I forgot to mention is hypoglycemia, which obviously, as we all know, is life-threatening.
Fantastic. So there's a pretty good solid list there of immediate life threats in patients with eating disorders that we need to be aware of. There's the cardiac ones, there's the electrolyte ones, there's this acute gastric dilatation that ends up with necrosis and perforation of the stomach. There's Borje's syndrome, there's pneumothorax, there's intracranial bleeding, there's this SMA syndrome, which is a particularly interesting one, and there's hypoglycemia. Let's move on to the treatment of the person with an eating disorder. So if there's any life-threatening complications like we just discussed, we're going to address those directly. We're not going to talk about those here. But any comments just with the initial ED management of patients suspected of an eating disorder? We already had mentioned that we don't want to be fluid bolusing these patients because some of them could have congestive heart failure. Anything else we need to know in the emergency department that we should or should not do to help these patients with eating disorders?
Yeah, absolutely. And just to, readdress the IV fluid boluses, they may have reduced cardiac output and CHF, so that's not a wise idea. But the other thing is giving the IV fluid bolus to fix their tachycardia or fix their hypotension. That's only transiently making the numbers better to make you feel better. They don't need IV fluid. They need nutrition. That's it. I want to make a particular point about do not give any IV fluids that contain dextrose, which of course is a very common maintenance fluid in our pediatric population. With these kids, don't do it. Increases their risk for refeeding syndrome.
Those are some important pitfalls about what not to do in the emergency department with these patients. You want to avoid IV fluids. You want to avoid glucose. We've touched a bit on this already, but I want to go a bit deeper into how best to communicate with patients and their families about their loved one with an eating disorder, and how and why how we communicate is so important. Dr. Martin, can you give us some tips on how to communicate with patients suffering from an eating disorder, how to talk to their loved ones, and why it's so important to provide compassionate care, truly compassionate care for these patients?
So patients suffering from eating disorders deserve the same attention and compassion as those suffering from other serious medical illnesses. I want to highlight a few distinct pieces about an eating disorder in terms of why communication is so important and how to tailor your approach to communicating with families. Really important to understand the fear and validate the young person and the parent's distress. These patients are terrified. They're in fight or flight mode. They may express anger as their underlying form of anxiety, so don't take that personally. And remember, they're in a starved state. Their cognitions and emotions are not baseline. They're not themselves. So please approach them with empathy. And if you can, approach the interaction with the idea of getting them out of this fight or flight state so you can try to get some traction with the young person, whether it's admission or getting more details on your history. The second thing, this is a common, so we talk about separating the patient from the disorder, externalizing the illness. It's a very common therapeutic approach we take in adolescent eating disorders. The idea is that there's this beautiful, bright, young person sitting in front of you, and unfortunately they've had this alien come into their brain and take over their life, this eating disorder. Yet there's still that young, beautiful, bright teen who's there, but right now they can't navigate the world properly because this eating disorder is taking over. So helping families understand, or as a healthcare provider understand, that if there's manipulative behavior or if they're not forthcoming with information, or they are seen as deceitful, they're hiding food, or just seeming like they're not being their usual good kid self, it's the eating disorder. So we talk about sort of, I can see that this eating disorder is making you do X, Y, Z. I can see that the eating disorder is really challenging you here, and I need you to go into the hospital so we can keep you safe. It's a way to avoid blame and criticism. It's a way to teach parents how to understand what's going on with the young person, and it's a way to see the adolescent for themselves, that they're not at fault of this. The third thing, really, really important, don't minimize the illness. Be very clear about the expectations. So again, unlike other pediatric conditions, we're not trying to create more anxiety when a young person comes in with an asthma exacerbation. We're kind of trying to control the situation, provide really great medical care. We're keeping it calm and saying everything's okay. We're going to take good care of your child and everything's fine. The difference with an eating disorder is because many may not feel sick or they don't see that there's a problem, we have to be mindful about our wording. So we can't say, oh, I'm glad you came in. I'm really reassured. You have a normal exam. Your vitals are normal. Your lab's normal. You can go home. Everything's okay. Because what that young person hears is potentially, see, everyone is crazy. I'm fine. I'm going to keep doing what I'm doing. And this was all so ridiculous. Or worse, the doctor just said I'm fat and what I'm doing is not working. Work harder, restrict more, exercise more, purge more. I'm clearly not sick enough. I think analogies are really, really helpful in communicating to a young person who, their light bulb hasn't gone off, and it might not. It probably won't go off in your visit. But an analogy I might use is the idea that you're driving on the highway, 100 kilometers an hour, and your gas tank light goes off. You're out of gas. Your body's gas light went off. You're not getting your period. Your heart rate's low. Your blood pressure's low. But when you're in the car, you're still driving 100 kilometers an hour. You don't feel different. You don't feel the car start to shake or kind of slow down. It keeps going. But we don't know at what point your body's going to keep going. And I don't know at what point your body's going to ultimately just crash and burn. I don't know in the car at what point the car is just going to stop. So really emphasizing the seriousness. So I think being empathic, but also being firm. You're okay to go home today. I'm really worried about you, and I'm going to make sure we have appropriate and timely follow-up. And you need to come back if things aren't getting better. So I'll sort of summarize that. Validate the distress, the patient and parent. Externalize the illness. Please avoid blame. And be clear about the expectations. Don't minimize the illness.
So important. I mean, these are exactly the things that can make or break an adolescent's eating disorder, whether they can actually get into treatment or not, and whether they crash or burn or actually head towards recovery. So super important, some of these, we don't really think of, how to communicate as actually having a massive effect on the outcomes of our patients. But I think in this case, they certainly can. Yeah. It's just so interesting because, a good third of our jobs as emergency physicians is reassuring patients. We see some really sick patients, but many of the patients, or even most of the patients we see, actually aren't sick at all. And really, we're just providing them reassurance. So with eating disorders, it's totally counterintuitive and totally the opposite. We should never just be reassuring them. All right, I want to move on to admission criteria. We've mentioned that emergency doctors are not great at picking up eating disorders. The literature also suggests we're not great at figuring out which patients with eating disorders should be consulted for admission. So, Dr. Tomlin, my understanding is that there's no great evidence-based admission criteria, but could you just give us a sense of which patients should be considered for admission and which patients are safe to go home to be set up with an outpatient program?
So admission criteria will definitely vary based upon which hospital you're at, which country you're at. However, the general rule of thumb is regarding bradycardia, heart rate less than 50, resting in daytime or less than 45 at nighttime, that person should be admitted. If there's orthostatic tachycardia, greater than 30 to 35 beats per minute, that's admission. If there's orthostatic hypotension with systolic blood pressure drop of greater than 20 or diastolic drop greater than 10, that's admission. If there is hypophosphatemia, that is usually admission. If there's hypokalemia, that is usually admission. If there has been acute food refusal, so if the patient says, or the parents say, they're refusing, they've had no nutritional intake in the past 48 hours, you send them home. That's not going to change. Refer those people.
So that's a really good list of general criteria. We'll have an example of admission criteria in the show notes for people to reference. And again, you should check your local admission criteria. I noticed that you didn't say anything about weight. So I'm assuming that a specific weight is not part of any criteria, Dr. Martin?
Yes, it is. So severe malnutrition alone can warrant hospitalization, despite the rest of the vital signs and labs being okay. This can be less than 75% of a median BMI. That's calculated by the current BMI divided by the median BMI for that young person's age times 100. The rapidity and magnitude of weight loss. So like we discussed earlier, if that young person has lost more than 10% of their body mass in 6 months, would be classified as moderate malnutrition. Severe is more than 10% in 3 to 6 months. So just think about 10% in the 6 months and they're hitting criteria. With patients with bulimia, uncontrollable binging and purging can warrant admission to break the cycle.
All right. That gives us a good sense of which patients should be admitted. And of course, just speaking with your local pediatrician or your local psychiatrist about whether the patient should be admitted. I guess the bottom line is kind of err on the side of speaking to someone about the possibility of admission because you don't want to be sending home someone inappropriately. All right, so that's about who should be admitted. The next level of care is outpatient management for those who are safe to be discharged from the ED. And these patients all need management. So they can't just be sent home and say, follow up with your family doctor or your pediatrician. They do need an outpatient program. And unfortunately, my understanding is that these are difficult to access, but it doesn't mean we shouldn't try. Dr. Tomlin, what are the sort of essential components of discharge planning for a patient with an eating disorder who does not meet criteria for inpatient admission? In other words, when is outpatient management appropriate? And how should discharge planning be handled to ensure continuity of care for patients with eating disorders?
Before we get into the actual follow-up, I do want to mention, depending on the eating disorder itself, you may want to do a bit of counseling with the parents before sending them home. If they are purely a restrictive patient, tell them to have something to eat in the emergency department before you discharge them. And they will not be discharged home until they eat something. Because if they're not going to eat it in front of you, to get out of the emergency department, you can just imagine what's going to happen at home. If the patient is using exercise as part of their eating disorder, it's a component of it, all exercise is forbidden until they are assessed as an outpatient. So that means no sports teams, that means no jogging, that means no gym class, nothing. Lastly, if the patient is purging with self-induced vomiting, that's a pretty hard one for the parents to tackle. But if they can, they should just be watchful and mindful for an hour after the patient eats, trying to minimize any bathroom time to try to block the vomiting. And the other key thing is if the parents happen to be on a diuretic, like furosemide or hydrochlorothiazide, tell them to hide it. Now that I said that, if everybody's good with going home, there needs to be very concise follow-up. There needs to be a clear plan. If your local organization has an outpatient eating disorder program that you can directly refer to, please do so. If your organization does not, I think it would be super important to get assigned follow-up within the next 2 weeks by either pediatric outpatient clinic, or if they're an adult, the outpatient general internal medicine clinic, so that their vital signs, blood work, ECG, everything can be monitored again.
Perfect.
Sometimes I write a prescription to the family, to the child, to say, your prescription is food, 3 meals, 2 snacks, and no physical activity.
That's a good way of thinking about the medicine for eating disorder is food. Interesting. I want to talk a little bit more about outpatient management, not because emergency physicians will be doing this, but because we need to understand how these patients get better. So, Dr. Martin, could you just review for us the evidence-based outpatient management for these patients? Like, what actually happens to these patients? What's the highest likelihood that they're going to recover?
Sure. So when we look at outpatient treatment options, so there's outpatient treatment, which is typically once a week of therapy, which I'll get into. The next level up is a day program. If the hospital program offers that, that would be more intensive, 5 days a week. So the outpatient program is typically a multidisciplinary team. So you have a therapist, medical provider, dietitian, ideally a psychiatrist. And the first-line evidence-based treatment in adolescents with eating disorders is family-based therapy, FBT. Briefly, the tenets of family-based therapy are to empower parents to take control of the young person's eating and decisions around eating and exercise. It's broken up into 3 phases. Patients are seen weekly along with medical, and the initial phase and the primary goal initially is focused on weight restoration, because we know that early and rapid weight restoration is a positive prognostic factor to recovery. A young person is less likely to respond to individual therapy when they're malnourished. We cannot work on body image or the whys of the eating disorder, or what I often sort of refer to as the bottom of the iceberg, when they're bradycardic and their brain is malnourished. So that is the goal. So parents may say, well, we need to get them an individual therapist or something. And some may need that. So again, FBT is not for everyone, but it is the first-line evidence-based treatment, and it's weight restoration primarily. The therapist is there to support the parents. The second phase of it, moving forward through treatment, is, and this is when young people might come into the emergency, is they get some autonomy back into decision-making around what they're going to eat, their exercise. So I bring that up as sometimes that autonomy is too early, or it's not working well, or they may have weight loss. And then the third phase is really focused on relapse prevention, body image, and a little bit more individual work.
All right. Well, that gives us a good sense of the different levels of treatment for young people with eating disorders. Could you just give us a sense of some of the resources we might give to parents in Canada and the US, or just online resources?
Yep, there's some excellent ones. Feast is a website. Families Empowered and Supporting Treatment of Eating Disorders. It's a nonprofit support group for parents and has fantastic resources, videos, evidence-based lectures you can watch. A parent forum. So I really think that's a wonderful website. Other websites, Kelty Mental Health. They have videos for caregivers of young people with eating disorders and strategies to support a young person while they're trying to eat. Very tangible, specific.
And Kelty is
Kelty.
Got
Yeah.
it.
National Eating Disorder Association is another nonprofit organization that has excellent resources for parents. There's some great books. I know we're much more online these days, but Help Your Teenager Beat an Eating Disorder is one that's quite common. How to Nourish Your Child Through an Eating Disorder, a simple plate-by-plate approach. Brave Girl Eating, A Family's Struggle with Anorexia, is one that some families have found helpful. And When Your Teen Has an Eating Disorder by Lauren Mulheim. She's a well-known psychologist in the eating disorder field. If there's interest in learning about the medical complications of eating disorders, a book called Sick Enough is also a good resource.
I've learned a ton about eating disorders, and usually at the end of a podcast, I guess that our listeners have learned something about what we've talked about. In this one, I'm going to guess that they've learned more than just something, but that they've learned an enormous amount, because we do know, based on the literature, that emergency physicians are, how shall I say, extremely undereducated when it comes to eating disorders. So thank you both so much for your insight into eating disorders for the emergency provider. Before we go, if there was one message you'd like to leave our listeners with about eating disorders, what would that message be? Dr. Tomlin?
Eating disorders are super common, they are super sneaky, and they are super deadly. They are a medical emergency. And we, as emergency doctors, we have a duty of care to these patients and their families when they come and see us in the emergency department.
My take-home point is young people with eating disorders are sicker than they look. Maintain a high index of suspicion, and don't be reassured by a normal exam, vital signs, and labs. Please err on the side of caution. As an emergency medicine provider, your role is a lot bigger than you realize, and you can make a significant impact on a young person's life.